Hello, I'm Adele Framer and founder of survivingantidepressants.org, which offers peer support for tapering psychiatric drugs and recovery from withdrawal syndrome. It's my pleasure to announce today that we're going to be talking with Dr. Ellen van Leeuwen, a Belgian GP and clinical pharmacologist with a PhD in deprescribing psychotropics in primary care. As a GP, she sees patients at a community health center while also working as a researcher at University of Ghent. At the university, she teaches medical students how to prescribe medications and conducts research on the appropriate use of psychotropics, including deprescribing. Among her research is the paper Never Change a Winning Team, GP's Perspectives on Discontinuation of Long-Term Antidepressants, and a landmark Cochrane review of antidepressant randomized controlled trials utilizing a discontinuation design. It's called Approaches for Discontinuation versus Continuation of Long-Term Antidepressant Use for Depressive and Anxiety Disorders in Adults. Today, she will present some of her findings on deprescribing long-term antidepressants and share practical tips for doctors. We'll have a short question and answer period at the end of Dr. Leeuwen's talk. Please enter questions in the Q&A box at the bottom of your Zoom window. That's a little box that says Q&A. It looks like two little speech bubbles. There will be a general discussion session at the end of our agenda on Saturday if you would like to continue the discussion. Please send any other comments to info@iipdw.org. I must remind you that this presentation does not contain medical advice to individuals. Thank you, Dr. Leeuwen.
Thank you for the lovely introduction. So today, wait 1 minute. You see my screen?
Yes.
Okay. It's a PowerPoint, eh?
Yes.
Okay, thank you. So yes, I'm Ellen van Leeuwen. I'm a GP and pharmacologist, and I'm based in Belgium. And my interests are polypharmacy and deprescribing, but with focus on the appropriate use of psychotropics. I have no conflicts of interests. As Adele told us, I did my PhD on deprescribing psychotropics in primary care with focus on antidepressants. So I will show today some findings of my PhD and also mixed with some practical information for discontinuation of long-term antidepressants. So what I will bring today, a short introduction, my studies, what now, practical information, and some take-home messages. Okay, so I'm a GP since 2008. This is our practice, and it's in a deprived area with a lot of high buildings and in a poor, and also a poor area. So since I started in our practice, I see that long-term use of antidepressants is very common. But as you all know, as antidepressants are used for depression and anxiety, they are recommended to continue 6 months after improvement for first depression and 2 years if high risk of relapse. However, long-term antidepressant use was very common, and I mean it's for more than 5, 10, even 15 or 20 years. And I think it's also important that I will focus on antidepressants for depression and anxiety. You can give them also for pain-related disorders, but that's only in a small minority. So here today I focus on antidepressants for depression and anxiety. So why is this important to have a look at it? Because in Belgium, 1 of 10 take daily an antidepressant, and more than 1 year, more than 70% take it for 1 year. And then we know that more than 40%, more than 4 of 10 take it longer than 3 years. But this is not only in Belgium, it's worldwide. Also in UK, we see that many people take it longer than 2 years. And in United States, it's even more common in older people. You see it's 20%, and especially in nursing homes. And in the last years, we see that there is an increase in patients who are stable and feeling well for many years while using an antidepressant without a clear indication to continue. In Belgium, it's so that the mean duration is 2.7 years, and this is a bit in contrast to what I told before, that the recommendations are up to 6 months or 2 years if high risk of relapse. Here you can clearly see the rise in long-term use. This is in Belgium. The use of antidepressants, it's a bit stable, around 30%. And then here you see the long-term use is more than 1 year. You see it goes up. And this is in Belgium, but is also worldwide, as I told before. Dus in primary care, you have typical long-term antidepressant users with 1 or no previous depression. And it's very important to look at long-term antidepressants because we know that they are associated with risks. These are very common and I think well known, and the stomach problems, sleeping problems, weight problems, weight increase, also emotional numbing, but also less visible. This was the sexual problems. Less visible is emotional blunting, feelings of psychological dependency, and hypotension, of course. But there are other rare adverse events, luckily rare, but they can be very serious, and you see him here. So they are not without risks, and we also know that the risks persist. After 1 year, 2 or 3 report still side effects, not only 1, but at average 2.9. So, given the depression guidelines with the recommended duration, given the rise in long-term antidepressant use, and that the fact that there is no evidence that they work for many years, and the well-known risks of harm, I was, as a GP in 2017, I was looking, is there evidence for discontinuation of long-term antidepressants? And at that moment, I started, so I looked at in the literature about what's known about the effectiveness and safety of approaches for discontinuation, but at that moment there was there was not real good information that helped me in my search for an answer. So I started a Cochrane review about this topic, and we started in 2018. So this is a bit surprising that it's as 1 out of 10 people taken antidepressants, but there was no Cochrane review about this topic. So this illustrates the lack of interest in this topic. But luckily, the last years, and there is more focus on it. So maybe some know the Cochrane collaboration. In fact, a Cochrane review is seen as the golden standard in scientific world. So this is really, if you want evidence, you look to the Cochrane collaboration library. So this is a this is the golden standard. It's a very strict methodology. I will not describe it in detail, but you can read it in the handbook. And most important, what are our results? Maybe also important to mention is that I was the lead of the review, but it was a very international team with also Mark Horowitz and also Tony Kendrick, and then also some, so both are based in UK, and then also some colleagues from Australia. And we were also a multidisciplinary group with GPs, pharmacologists, psychiatrists, psychologists, and methodologists. So what are our results? We could not make strong conclusions. There was a lack of studies focusing on deprescribing antidepressants, and most in studies included people with recurrent or chronic depression, and the results suggest that discontinuation is associated with higher risk of relapse. However, there were some important limitations. There was no difference between withdrawal and relapse. I will explain this also further, but of course, making a difference between both is important, because in the last years we know that withdrawal symptoms are more frequently and may be similar to symptoms of relapse. So it's very important if you do a study to check, is discontinuation better or safe, even safe, or the safe of discontinuation. You need to know if it is withdrawal or relapse, of course. Is this problematic? Yes, because people, if we know that there is a great fear of relapse, so it can be an important reason to restart antidepressants if you feel not well and you think, oh, maybe it's the depression is returning, so I will start again my antidepressants. Instead of, oh no, this is a withdrawal symptom, so I need to reduce slower. So, and another important limitation was that all withdrawal schemes were quite rapid, and these are in contrast to the current guidelines that recommend slow tapering. We also saw that high intensive psychotherapy may increase successful discontinuation. So that was a good result to know. But many questions remain. I think the most important is we've done this study, and in this study, maybe that's important also to mention that a systematic review looks at the evidence and all the studies that were done before, that the studies that assessed discontinuation versus continuation. So we did this review, we looked in the literature and we found 33 studies, and due to the many limitations, we could not make a conclusion. So this is really an important result, because it shows that there is no answer to this very important question. And also, in some there are also other questions that we could not answer with this review. So, for example, discontinuation in persons with one or no previous depression. Also in older people, there were only 3 studies with a high risk of bias. Anxiety, there were only 5 studies. It was also not clear how do we stop an antidepressants. We could not give an answer based on this review. Also, the issue with distinguishing relapse from withdrawal symptoms was not clear. And also, as as I said before, a high intensity psychotherapy may help, may improve successful discontinuation, but of course, this is not accessible for everyone, and I think it's also not, we as society, we cannot afford that to everyone. So a low intensity psychotherapy is probably a better accessible, but that's never assessed before. So there were many questions, and was quite disappointing after, it was a very hard work to do this review. I think it took me 3 years, but it was very disappointing that there wasn't almost no evidence how to stop, and is discontinuation safe, effective. However, there is good news. In future, of course, we need better studies with other designs, with better designs, with more people that are relevant for practice. And there are some ongoing studies. The REDUCE study in UK that is already finished. There are 2 studies in Australia. There is the study in the Netherlands. However, it is stopped because of lack of funding, and maybe also in the future in Belgium, my own country. This review gained a lot of attention, and the metric score was 335, quite high. And also we were mentioned in the BMG news, and also in the Belgian media. I'm often cited, and so more. So I was also in the on the national radio. So this is the first part of my presentation, and it shows that even now we are 2023, and there is a lack of evidence to on this topic, which is quite disappointing. I think if we know that so many people take an antidepressants for many years. And then on the other hand, of course, I'm a GP, I'm based in practice, I see patients, and I see that it's very difficult to stop long-term antidepressants. And this is, and I see that successful discontinuation depends on patients, but also on GP-related factors. And in my PhD, I looked at the attitudes of patients and also GPs towards discontinuation. And I did this by qualitative research and interviews, so in GPs and patients. What were my findings? So antidepressant use longer than recommended without evaluation is very frequent, it's very common. We saw that deprescribing, the stopping an antidepressant is a very difficult decision for the patient. And what we found that there was a high fear, great fear of relapse, which is not, which is understandable because many people thought, yeah, the antidepressant helped me when I was so bad, when I was so depressive, that yeah, I don't want to go back to that period. It is understandable, of course, because it was such an unpleasant period. Other people were also a bit unsure about the antidepressants because sometimes they think, yeah, maybe I can stop, but I'm not sure. But the great fear of relapse dominated, so they were hesitating to stop the antidepressants. And then there was also a group that was feeling well with the antidepressant and just want to take further with it. Important to mention is that these are quotes from patients in my study. They are published. But of course, this is for the group of patients that I interviewed, so you cannot generalize it. but I tried to, there's a methodological technique that I tried to have data saturation, so it gives a good idea what long-term users think, but you cannot generalize it to other countries. What I also found that people we saw that they are quite dependent on the antidepressants, and that they saw themselves as I cannot live without the antidepressant, because if I have problems, how will I deal with them? So also they found themselves, we found that they have limited confidence in their own, and it was also influenced by their previous experience with stopping. Many stopped sometimes just 1 week or some days, and they felt not well, and they were worrying, is this the depression that comes back, or are these withdrawal symptoms? So you can all find my results in this article, Should I, Can I, Dare I? And I think this title illustrates well the findings, and it's open sources, so you can read it if you want. Then, so the patient, difficult decision, and they wait on the GP. And we see, they also said that, we are never told to stop the antidepressants, and because of all their reasons, they wait on the GP, because they have a great fear of relapse and all the other barriers. They wait on their GP, but then they told us, but no one says stop taking it. And then we decided to look at the GP side, and we found also that deprescribing is a difficult decision for GPs. And the main reason was that, for GPs, they were quite comfortable with the long-term antidepressants. They did not perceive it as a big problem. There was one GP that said, never change a winning team. People are well, they have no side effects, so why should we stop it? And also there was a high risk, the fear of risk of relapse, and altogether this also resulted in waiting on the patient requests. You can also read my results in Never Change a Winning Team, which was published in 2021. And so altogether, you have on one side the patient that waits on the GP, and on the other side you have the GP waits on the patient, and with them, between them, there is a big fear of relapse. And as a result, the antidepressant is continued without any evaluation, without discussing the pros, the cons of long-term antidepressants, and it's quite status quo without any change. So I think this is this illustrates really well the difficulties to stop a long-term antidepressant. Okay, next, what now? So what do we know? Or Cochrane review, okay, no hard conclusions possible about approaches for discontinuation of long-term antidepressants. However, we know that there is a quite good prognosis for people in primary care with depression. We know that up to 70% recover without medication within 6 to 1 year. there is no proof of evidence for benefit for the majority of long-term users in primary care, with often one or maximum two depressions, previous depressions, with low risk of relapse. And I think long-term antidepressants, and that's why we also saw in our review that it may be appropriate for a small group with recurrent depression, but also then evaluation of the pro and the cons is required, because things can change and people can have other medication that can give problems with the antidepressants, or they can develop other diseases that may influence the antidepressant. So I think a regular evaluation of the antidepressants is really required. So what do we know about the qualitative work and what's important? There is not one solution. I think very important that we saw in both studies, there is a lack of understanding of knowledge of the risks of antidepressants, and also we saw that that both clinicians and patients, they really they believe that they are stable even after 20 years, 30 years to the antidepressants. So it's also important to mention that there is no evidence that shows that an antidepressant works many years. And then I think, as a GP, I think it's very important that the doctor should initiate the discussion of deprescribing, and if you deprescribe, then a regular follow-up is required to support the patient. I think this is the most important for all doctors that are in the audience. We also saw that involvement of a trusted person can help. Imagine if your partner, if you take a long-term antidepressant and your partner is telling you, no, I don't think it's a good idea to stop the antidepressants, and maybe you can become again depressed, and then it will be problematic for children who will do them to school and so on. So the opinion of the family and the friends are very important, but we also saw that they can help the patient to stop an antidepressant. So I really would recommend to, and if you want to stop, tell it to someone, take someone in trust, and that person can help you and can support you. I think also sharing success stories is important, and that's also why I support the Institute, because we really work on this topic. And we also saw in our study that success stories for GPs was quite not surprisingly, if a patient requests discontinuation, then this is a very important facilitator, and then as a doctor you really need to go you really need to take this opportunity and to consider discontinuation. The health issue, there was if someone is pregnant or another disease, or other medication or a new medication, then it's also an opportunity to stop an antidepressant. And then a positive life event, for example, if someone is happy because of a grandchild or a new hobby or a new partner, that's also the moment that you can stop an antidepressant. In the interviews with GPs, we saw that there were many barriers, But these are 3 situations that they told us, discontinuation is possible. So I think this is very important, that in these, it was not only possible, but also successful. So I think this is also important for the doctors that take this important message. And then they also told us that informing the patient and informing about withdrawal symptoms and slow tapering reduces the risks of experiencing withdrawal symptoms. So they told us that once someone decides, okay, I will stop, I will do this, and you support the patient and you taper slowly, that it's possible to stop, and not only possible but also successful without restarting. So this is also quite reassuring that it's possible, and it's possible but also successful. And this is important because we know that the withdrawal symptoms are common. There is some discussion about it, but let's say it's about 50% that experience withdrawal symptoms. 50% of them experience them, of describe them as serious, and they can last from weeks to months. They are, for all antidepressants, described unpredictable. It's very individually, and there is a broad variety of symptoms possible. Here you can see the list of withdrawal symptoms. And this was also mentioned here in the quote, and I think this describes good what someone feels when they stop. She describes the physical symptoms, headaches, stomach problems, but also psychological symptoms, getting negative again. And I don't know which of the two is right, actually. And then that's the reason why I never stop. So I think this is really what the problem is. And it's very... yesterday I had a patient in my practice, and she describes the same thing to me. It was someone who takes it already more than 20 years an antidepressant. It was the first time I saw her, and I asked some questions about it. And then I also asked her, have you ever stopped before or tried to stopping? And then she said, yeah, I stopped once 1 week, and then I felt bad, and I was not feeling well, so I started again. And then I explained her that the withdrawal symptoms, they are not only the physical symptoms, but also psychological symptoms are possible, anxiety, depressive mood, and then, I don't know this is new for me, she told me. So I think this is very important. I think many people know, I think there is now an increased recognition of withdrawal symptoms, but it should also include that it's also possible that anxiety and depressive mood. I don't think this is well known. So how can you make the difference between them? Withdrawal symptoms are typical after hours or 1-2 days. Relapse is even as rather after weeks or months. Type of symptoms is the physical symptoms, and the psychological symptoms are, of course, more. Withdrawal symptoms are, of course, physical symptoms and psychological symptoms, and in the relapse it's only psychological symptoms. I made a mistake. And then if you restart an antidepressant, it improves quickly if it is withdrawal symptoms, and it takes longer in case of relapse, and then it's several weeks. So this is how you can make the difference between withdrawal symptoms and relapse, also for patients or for doctors. So some tricks or tips for discontinuation, of course, non-evidence-based, given the lack of evidence for this topic. Provide regular medical follow-up, and I think this is also important for patients that you have the right to ask medical follow-up by your doctor. Of course, reduce slow, at least over 4 weeks. There are some guidelines, and I put here the UK flag because this is these are the guidelines from the Royal College of Psychiatrists in UK, and they have some tapering schemes. Also in Belgium, we have some tapering schemes that are produced by the Belgian Center for Pharmacotherapeutic Information. And you see here, it's, this is Dutch. For example, this is one, citalopram, and if it is at 20 milligram, you can reduce it to 10 milligram for 4 weeks. And then after it, you can stop. And that's if there are no risk factors. And this is in UK, it's a bit, it's a reduction of the dose by 50%. And this is also for citalopram. And it's, you see it's slower, and this is because the dose is higher. So it's slower if higher doses and symptoms in earlier stopping attempts. And you see here for the Belgian tapering schemes, the slower scheme in case of risk factors. So high dose or previous withdrawal symptoms. And then some people may know it, and then it's you follow more an hyperbolic tapering scheme, and then the last doses, what you see here, is step 4, 5, 6, 7. It's really small doses to get down to 0. The big problem is that in Belgium, it's not available in commercially products, so the small doses should be made by the pharmacist, and this can be quite expensive. So you should discuss it in all country with the pharmacist for the most practical and economical solution. And even, for example, for the slow release products, you cannot make them. So the pharmacists cannot make smaller doses. So this is really a big problem. Even we are very close to the Netherlands that tapering strips, in the Netherlands, as you know, tapering strips are available to reduce very slow with low doses, hyperbolic. You cannot do it in Belgium because it's illegal to import tapering strips from the Netherlands, because that's the law. It's very complicated, but it's the law, and it's actually not legal to import them here. Okay, so these are my tips. And then also, I think the most one of it's a very important one is the stop the serotonin meat, because then you think, okay, I need this and I cannot without the antidepressant. So this is, you should forget this. I see Adele, I will just 5 minutes, okay? So some extra tips and tricks. Stopping an antidepressant starts really at the initiation of the antidepressant. It's very important to mention that it's only for short period to support you, but it's not long life. And restarting is not a failure, but it's a kind of a good clinical care. GP is a navigator, and a pharmacist can help you also. And focus on positive things and avoid, because we saw that many people have really fear of relapse. So I think it's very important to be positive and focus on recovery. You have done the recommended duration. So my take-home messages: long-term use is common. It's rising also. Evaluation of the pro and the cons is important. Stop the serotonin because this does not help discontinuation, and it's also not true. Stopping starts at the initiation of the antidepressant, and it's a journey, and it can be sometimes a bit difficult, not easy, but it's not a solo travel. You can have the support that you need. It's a mission possible, I think. Okay, so this is the end of my presentation. So many thanks for the Institute, for the opportunity to share my findings, and the audience to be here on a Saturday evening. And if there are questions, I'm here.
Thank you, Ellen. We have several questions, and they're very good questions. One has to do with a lot of patients talk to their GPs and they try to go off their drugs, and then they get withdrawal symptoms, but the GP says that they've never seen withdrawal symptoms before. Is this something that's changing now, or is this something that you see pretty often, that the GPs just really are not aware of withdrawal symptoms?
Yeah, but of course, I think the focus and on discontinuation is just since a couple of years. Before, even in the NICE guidelines, they recommended to discontinue within 2 weeks, and withdrawal symptoms are not very serious. So I also learned when I was at medical school, okay, discontinuation is easy, not so difficult. It's not, they are not well informed, but it's not only they are not guilty because it's more an society problem. I think that we had that they were. I think the Cochrane review shows also that there is no good evidence. So it's also the researchers that did not pay attention to this topic. And of course, there's a big influence from the medical industry.
Right. I just wanted to clarify for a moment that I believe that in the Cochrane review, your team looked over, it was dozens of studies. What was the number of studies initially that you were looking at?
Yeah, there were, I think, I'm not sure, about 5,000.
Yeah, there were many studies, and you got down to 33 that met your criteria. But as I recall, only one of those studies among the 33 had protocols to distinguish withdrawal symptoms from relapse, and that was a study regarding tapering desvenlafaxine, and it was done by the drug company to show that withdrawal syndrome from going abruptly off of 50 milligrams wasn't any worse than going off of 25 milligrams. So it was an argument that they presented to the FDA that they would not have to provide varying doses of desvenlafaxine, which at that time was branded as Prestige. So there's only one of the 33 that had the distinguished withdrawal symptoms from relapse. And among the other bunch, I believe there were 2 altogether among the hundreds that you looked at. If I remember correctly, that's how it worked. There's very, very few of those studies had any way of distinguishing withdrawal from relapse. In your so that was the state of the art for psychiatry for many, many years, which also got communicated to other prescribers. Now, in your opinion, in your experience with GPs, do you think that if GPs got information about distinguishing withdrawal from relapse, that they would be able to do it?
Yeah, I think here in Belgium, things are changing, luckily. And now it's because of some lobbying, it's a priority for the health department. So discontinuation of long-term antidepressants. So there will be some budget for it, and there will be some implementation projects. So I'm also one of the experts in the committee, and I think one of the first things is, of course, educating the GPs and about discontinuation. Because also there is a lack of information in the guidelines, and it's also only just last year that the NICE guideline has been updated. So it's a very the reasons why this is such a difficult topic are not only the GP, but it's a broad level. So I'm very happy that in my country that the health department focus on this topic now.
Right. So you feel that in a common sense way, if GPs got the information, that they would be able to apply it. Do you have any rules of thumb that you've developed for yourself for recognizing withdrawal symptoms?
Well, I presented the table, and it's when I think 3 important issues are when they start and which symptoms, and what's the effect of restarting. And also a practical tip is ask your patient if this is if the symptoms that they experience are these the same as the symptoms that were when an antidepressant was initiated for. I think there's also an important a practical thing and easy to ask the patient. But I see when I see it was this summer I really saw a patient she was on holiday, and she had not enough medication with her, and then I saw her the day that she came back from holiday in the evening, but it was in the period of, it was also here a big COVID wave. So she was quite feverish and agitated, and a bit, was not aggressive, but she was so, it was very clear she was not normal. I described this case because it can be very serious, and you really see, patients are suffering from it. It's that case opened my eyes from, it can be very serious. And the thing was, when I did an examination, but a big one, because I thought maybe there is any other reason, because you think, maybe she has some problems with her heart or anything else. It was not the case. So, and then I thought, okay, maybe it's because the antidepressant that had been stopped for some days, and we started again, and after the weekend, it was Friday evening, after the weekend, she was perfect.
So she seemed very seriously ill when she went off her antidepressant.
Yeah. And I was wondering, when I told my colleagues, what if you had seen her? What would your reaction be? Because I was quite confident because it's my topic. So I thought, yeah, this will be withdrawal symptoms. But I don't know what would my colleagues have done.
Yeah, yeah. We have a request that you turn off the screen sharing. Oh, thank you. Okay. Yeah, along those lines, how successful have you seen the 4-week tapers? How successful have they been in your experience?
Well, I think it's they are in Belgium. We also follow the Dutch guidelines, and there you have two options. If there are no risk factors, you can go. You can taper over 4 weeks, and you reduce it, and after 4 weeks you can stop it. Or if there are high risks of withdrawal symptoms, you go very slow. I know there are some pro and cons about this tapering schemes, but yeah, these are the guidelines at the moment. So and I know you can say, oh, this is too slow, but actually at the moment, I think the most important is discuss it with your patient. What is for him or for her the best tapering scheme? And often you see, yeah, you discuss, okay, what do you think? You ask it, what do you want? And often, yeah, it's slower because people, they have a bit fear. So, and also after 2 weeks or 4 weeks, when you see your patient, you ask, how is it going? And if he is not feeling comfortable, okay, just we just stop the tapering for 1 month, we stabilize, and then we start again tapering. So I'm not so really focused on the correct, it's every week. It's also impossible to see your patient every week in practice.
Mhm.
It's too busy. You cannot do this. So I often, when I support a patient tapering, then I call him or her after 1 week. Okay, how is it? Is feeling well or no? Okay, I will call you back after 1 week, and that's how I do it. And when he tell me, okay, next week I have a big, and for example, after 1 month, and we want to stop, we were planned to stop it, and he tells me, no, I'm not feeling well. I'm not comfortable. It's busy period on my work. Then I just say, okay, we just wait another 2, 3, 4 weeks, and so it's very patient-centered tapering.
Right, right. So you'll check in with your patients every week while they're tapering.
But that's I think that's important. But some, of course, they don't need such support. It's very individual. So some people, they say, no, it's okay, just call me after 4 weeks. I think you need to look at your patient, and as GP, you know your patient. And yeah.
Do you foresee a need for psychological support for people who are tapering, perhaps to supplement the monitoring by the GP? Do you see a need for psychological support for people who are tapering?
Well, I think some people will need psychological support, but it's not common now. So psychologists are not trained for supporting patients that are tapering. So I think first we can involve them in the discontinuation process, but they need to be trained for this topic. And of course, here in Belgium, you have some waiting list for psychological treatment. So, and also, I think you also know, if 1 of 10 people take an antidepressant, it's impossible to refer everyone to a psychologist.
Mhm.
That's impossible. So I think really as doctors, we also need to support and to do this and not send it all to the psychologist. But
Right.
some people will need it, and this was also assessed in the REDUCE study in UK, and these results will be published soon, I think. Let's hope.
So in your practice, you will, it's very individualized. And one of, I guess you could say, a risk factor is whether the person is psychologically prepared to reduce their drugs. And for that person, you might go extra slowly or be extra cautious. So that's among your risk factors. Would you say that that's the primary risk factor for tapering?
Well, I think there are several risk factors, but it's also when sometimes I see patients that just stop their antidepressant on holiday and then without any issue.
Nothing
and then
happens.
I see them and, oh, you stopped your antidepressant? Yes. Okay. And I've tried for several years to convince them to stop it, and then they just stop it without any problem. And so I have also patients like this. So it's very individual. You cannot predict it.
Right, right. So that it makes it really difficult to choose to predict a tapering scheme in advance.
Yeah, and that is also if you are a researcher in this topic, it's not easy, and then you see this in your practice, and you can it's put your foot on the ground. You tell it in English, yeah. Then okay, you know, okay, some people just stop without any issue.
Yeah. Do you have you seen protracted withdrawal syndrome? And what how might GPs be prepared for it? Because as you say, there are so many people taking antidepressants, and people sometimes will very spontaneously go off their drugs and perhaps not tell their GPs immediately, and then time goes on and it becomes a protracted withdrawal syndrome. Is this something that you've seen in your practice?
Yeah, but sometimes you see that people can have very serious and long-lasting problems. But I see that in the, maybe Adele, if I may have the word, I see that Peter is asking some questions about the low doses made by the industry. Of course, Peter, I agree that it's also the responsibility of the authorities like FDA, EMA, that they should ask the pharmaceutical companies to put some low dose to make it possible that an antidepressant, that medication can be stopped. It's unbelievable that they do not have low doses of each antidepressant on the market. I think if you should know, if given the increased knowledge of this topic, of this issue, it's unbelievable that this has not been asked by these authorities who have the power to ask this. So, and I completely agree that this should be available, of course. And that's why I do my research in this topic, and I try to influence also in Belgium the government, and of course.
That is
and also the thing is, and I saw also some issues about tapering strips, is also that they are not reimbursed, of course. So it's very expensive. I calculated once, it's more than that's 70 euro, but I'm not sure about it. It's if you want to stop, this is a lot of money, and especially in my practice, most people are quite poor, so financial problems, so it's not affordable by everyone.
How do they manage to reduce their antidepressant? Cut up the tablets?
Yeah, often they are cut. Yeah, the pharmacist can help with that. But these are not official. Yeah, this is not a qualitative split, so a quantitative split. So yeah, low doses are very difficult, and this is what I also want to point out, that this is, of course, the responsibility of the authorities, that they should ask this. It's not me as a researcher. I can, of course, I'm trying to influence or government or health department for this topic, but you cannot expect that I do this. I mean, yeah. I think researchers, we need to focus on this topic and to ask to create awareness of this issue.
Yes. Currently, this is a barrier, that there are not there's not a range of dosages for each drug, and that presents a difficulty for both the doctors and the patients to be able to taper properly.
There is some goodwill here in Belgium. For example, we have now pharmacists are paid for making low doses of benzodiazepines. So I expect that the next step will be also for antidepressants.
Right. We have another question having to do with is there a possibility to do a follow-up study on the predictors of tapering chances? I think that means tapering success. Is there a way to test this, perhaps to find a model to follow?
Research costs money, so if someone wants to support me, let me know. It's not the problem is for this kind of research that an antidepressant is not expensive, yeah. It's only €100 for 1 year here in Belgium for the government, that is reimbursed, and then only about €25 for the patient for 1 year. So, and if you submit a proposal for research on this topic, then yeah, you need to make to show your cost savings for the government or for everything, and then yeah, it's not by stopping an antidepressant that I will save a lot of money. Yeah, it's
yeah, this is such an interesting topic, but unfortunately we've run out of time for now. Perhaps someday we'll come back and talk about this again. I appreciate your giving us this presentation, and also all the people who participated in the Q&A and in the comments, and very happy we're all coming together on this and talking about this important topic. So thank you very much for being here, and hopefully we'll see you on Saturday when we have more discussion. Thank you.
Thank you.